Welcome back to part 2 of this audio recorded lecture on stroke. So as I had mentioned, different parts of the brain control different functions. Three main parts of the brain include our brainstem, our cerebellum, and our cerebrum, which is divided into hemispheres and lobes. So we have right and left hemispheres, and because of the crossover design of the nervous system, the right side of the brain controls the left side of the body and vice versa. So when an individual has a stroke on the right side of their brain, they often have left-sided symptoms. And when an individual has a stroke on the left side of the brain, they have right-side symptoms. And then you can just see here in this chart, left brain functions versus right brain functions. And again, if their right brain is injured, then they will have impairments in these functions and vice versa to the left. So left hemisphere strokes causes weakness and paralysis on the right side, trouble reading, talking, doing math. They are more slow and cautious. They have trouble learning and remembering new information, and they may need more instructions and feedbacks. Versus right hemisphere strokes that have weakness and paralysis on the left side, they often have vision problems, problems with distance, depth, distinguishing front and back, problems with completing their ADLs, picking things up. They have short-term memory problems, they have difficulty with identifying maps, they have neglect of one side of their body, and they usually are very impulsive and make poor judgments. There are 4 lobes, the frontal, parietal, temporal, and occipital, and again, the effects of a stroke will vary depending on the brain region affected by that stroke. And it doesn't matter if it's an ischemic stroke where there's a blockage of blood flow to an area in the brain, or if it's a hemorrhagic stroke in which there is bleeding to the area of the brain. Clinical manifestations of right versus left, I'll let you go through those. Clinical manifestations continued, motor function impairments, more motor function impairments, and then communication impairments we'll briefly touch on, because communication impairments, especially with left brain damage, can be very common. The patient can experience aphasia, which is a total loss of comprehension and use of language. They can experience dysphagia, which is a partial disruption or loss of language, and it can be fluent or not. Please note that many dysphasias are mixed in nature, with impairments to both expression of speech and understanding speech that is given to them. In regards to communication, if Wernicke's area is affected, we might have impairment in understanding of spoken and written language. If Broca's area is affected, they may have problems with speaking and writing. And then this is just more of a visual. Again, in regards to communication, dysarthria can happen, which is a disturbance in muscular control of speech. They are unable to pronounce and articulate themselves well, so they know what they want to say, they just really can't get it out. Affect can be changed as well following a stroke, whether it be ischemic or hemorrhagic. Most oftentimes, patients can seem emotionally labile. Depression is a huge thing that can occur after a stroke just because of the change in body image, a loss of independence and function in their life, and this can trigger frustration and emotional responses. Memory and judgment can be impaired. Left brain strokes often, they're very cautious with their judgment, whereas right brain strokes, they can be more impulsive and their judgment can be impaired. There can be spatial perceptual alterations, although this is more common with right-sided brain strokes. They might neglect all input from that affected side. They can experience agnosia or apraxia, so an inability to recognize objects by sight, touch, or hearing, or an inability to carry out sequential movements on command. There can be problems with elimination function. Usually these occur quite common initially, but over time they can get better. They're not necessarily always permanent. Usually in the beginning they have almost UTI type symptoms, frequency, urgency, incontinence that may be intermittent or ongoing. Constipation can be a frequent problem because they might be more immobile than they are used to. Their abdominal muscles will become weak and they can be slightly dehydrated. Diagnostic studies overall are done to confirm that there is definitely a stroke there, that it's not a lesion or a brain tumor, and diagnostic studies are done to identify the cause of the stroke. So is the cause ischemic or is the cause hemorrhagic? These diagnostic studies include CT, MRI, and carotid ultrasounds. A CAT scan is ideally done within 25 minutes of the patient presenting, and it should be read within 45 minutes so that the patient can have prompt diagnosis as to whether or not this is an ischemic or hemorrhagic stroke, because the treatment is very much dependent on the type of stroke. The CT will indicate the size and the location of the lesion and differentiate the stroke between ischemic and hemorrhagic. They may do multiple CTs over a period of time because if the stroke is ischemic in nature, it may not be seen on the initial CT. It may not be seen until later on when we can actually see that some brain death has occurred in those specific areas because of the lack of blood flow to those areas. For a hemorrhagic stroke, although we can see those right away, we want to see, are they getting better? Are they getting worse over a period of time? And then finally, an MRI might be done to determine the extent of the brain injury and to really visualize the cerebral vasculature. But overall, when we talk about quick and prompt treatment of a stroke, a CAT scan should be the initial thing that is completed. In regards to treatment, there is some drug therapy, specifically something called TPA. It's given IV to reestablish blood flow through a blocked artery and to prevent cell death. It's for patients with acute onset of ischemic stroke. It cannot be used in a hemorrhagic stroke because it will increase the bleeding and it will not help the patient. They definitely need a CT or an MRI initially to rule out hemorrhage in order to be a candidate for TPA. They usually also need some blood work done as well. If they have a history of a GI bleed, a history of a previous stroke, or head trauma in the past 3 months, they will not be a candidate for TPA, even if they are indeed having an ischemic stroke. TPA produces localized fibrinolysis by binding to the fibrin in the thrombi. The action occurs as plasminogen is converted to plasmin. It's an enzyme action. It digests fibrin and fibrinogen, and it lyses the clot. So basically what it does is it gets in there and helps to dissolve that clot. In order to be a candidate for TPA, not only do they have to meet those previously indicated guidelines, but they also have to know the exact time of onset. So if family says, they just woke up in the morning and they were found like that, that's not an exact time of onset. They would really have to say the patient was last seen normal at this time, and then if they have that clear time of onset and they are within the 4.5-hour window, they may be a candidate for TPA. If you minus this video and open up your PowerPoint, you will note that I've included 2 links to 2 videos about this. Other collaborative care measures include preserving life and preventing future brain damage, maintaining adequate oxygenation, obtaining vital signs and ensuring they're within the normal limits. High blood pressure initially is quite normal. It's a protective mechanism. We really will only treat the blood pressure for an acute stroke if it's over 220. We want to manage fluid and electrolytes and look at their coagulation studies. Prevention is really the key, as previously mentioned, to decrease the morbidity and mortality from stroke. Rehab is a key component post-stroke. We want to maximize the capabilities of the patient and hopefully return them to physical, mental, and social well-being. Preventing deformities through contractures, maintaining and improving function through physio, and maximizing the client abilities is important. Teamwork and collaboration is essential, and teamwork and the approach to teamwork for a patient, who's having a stroke includes a variety of interdisciplinary teams. Which of the following factors related to cerebral blood flow most often determines the extent of cerebral damage from a stroke? Is it the amount of cardiac output, the oxygen content in the blood, the degree of collateral circulation, or the level of CO2 in the blood? The answer here is degree of collateral circulation. So cerebral collateral circulation, blood flow to the brain overall, is maintained by a network of collateral arteries in the circle of Willis, which lies at the base of the brain. In the circle of Willis, so-called communicating arteries exist between the front and back parts of the circle of Willis, as well as between the left and right side. So just kind of review what collateral circulation is, and we can talk more about that when we review strokes closer to exam time. So in order to study this material, some of the things you need to do independently is look up these manifestations on the left and also look up the information on the right related to the manifestations. So coming up in class, we will move on to cardiac disorders. I look forward to seeing you guys this week.